Hello, I'm Dr. Benjamin Levy. I'm an associate professor at Johns Hopkins School of Medicine and the clinical director for the Johns Hopkins Sidney Kimmel Cancer Center at Sidley Memorial Hospital in Washington, D.C. The management of recurrent thymic carcinoma post-curative intent therapy with either surgery or chemoradiation is constantly evolving. I can tell you that we haven't shared the same advances in thymic carcinoma with all these great targeted therapies that we have in non-small cell lung cancer. Nevertheless, we do have hints, we have data. I think importantly that patients who develop either local or distant recurrence for thymic carcinoma post-surgery and chemoradiation, or just post-chemoradiation, you need multidisciplinary approach. It's important to talk to the surgeons and the radiation oncologists and the pulmonologists. These patients need multidisciplinary care. It cannot be managed by the medical oncologist. It takes a village in this setting, and I think that's important. I think similar to other disease states, you have to define the progression. If this is truly just local recurrence, there may be an opportunity to perform surgery, depending on where the tumor is, or chemotherapy and radiation, or radiation alone. It would, again, depend on what the patient received at his or her initial treatment. When it comes to distant recurrence or systemic recurrence, post-curative intent therapy for thymic carcinoma, this is where things get a little less data-driven. We obviously would want to look at what chemotherapy they received at the first part of their regimen. So if a patient received concurrent chemoradiation as curative intent for their thymic carcinoma, and that chemotherapy regimen was weekly carbotaxol, and then they developed progression in other places, one could consider giving another active regimen that's not carbotaxol, like cisplatin, adriamycin, and cyclophosphamide, if that patient is fit. If, for instance, the patient never received chemotherapy and radiation, but just had received surgery and then develops a distant recurrence, one could consider carbotaxol. I would probably default to a regimen that wasn't used before, if there was a regimen used before. I would also look at the patient's fitness level, because full dose carbotaxol and full dose cisplatin, adriamycin, and cyclophosphamide, the CAP regimen, are difficult to give to some patients. So there are other alternatives, and I can certainly tell you from experience, the one that I like a lot for patients who develop distant recurrence after a curative intent approach is single agent pemetrexed. This is well tolerated. We've got some data published in 2018 showing a PFS in this setting of close to a year and a survival time of 2 years. This is the regimen that I deploy often when patients have distant recurrence post-curative intent therapy, whether it be chemorads or surgery. There's also been case reports of paclitaxel, case reports of everolimus. This is where the data gets quite thin, but nevertheless, certainly when you have this scenario, make sure you're talking to your other disciplines to see if there's any other opportunities outside of systemic therapy. And if you are going to just default to systemic approaches, try to use one that wasn't used in the first regimen, if there was a regimen used, and consult NCCN. I think this is where NCCN does a good job of really listing some of these nuanced studies and small studies with chemotherapy regimens that may or may not be active. These patients live quite a long time, so you can sequence these patients to different drugs over time. So, when we think about lung cancer, third, fourth, fifth line therapies may be difficult to give. Thymic carcinomas, you can do this. And so be sure to leave no stone unturned. Probably an opportunity to do next generation sequencing on these patients as well. There's been rare reports of intract fusions in these tumors, so something to look for. But again, it takes a village, a multidisciplinary approach, and consult NCCN when you're thinking about some systemic regimens. But my go-to has been pemetrexed post-curative intent therapy with a distant recurrence.